Start recording. Hi everyone, I just want to run through some webinars norms for you for those that have attended today. So you are muted and will be muted until you raise your hand, which you can find on your chat function, the little grey bar at the bottom of the Zoom. If you raise your hand, then we'll be able to unmute you and you can ask your questions. You can also type any questions into the Q&A function too, and we'll answer those as well. If you've got any technical difficulties, please get in touch with the chat. We're going to address written questions first, and then we'll move over to the phones. This webinar will be recorded and shared as well. I understand that Gemma, we're taking questions before Jenny and Manu are going to give the speech. So would you like to just say a little bit about that and then start with your slides?
Carla, I can't share my screen. Okay, so I'm hoping you can all see my slides now.
Yep, that's great.
Okay.
You might want to just make those full screen. There you go.
There you go. Yeah, so welcome everybody and thank you for joining us this afternoon. This was obviously supposed to be a face-to-face session, so we've kind of put together a bit of an online webinar and we've got some speakers joining us today. So I've got an agenda to run through. I think Jenny's just joining us as we speak, which is great. So I'm going to do a brief overview of the Accelerated Access Collaborative and our role as the Academic Health Science Network for the Northwest. We've got Jen Cohen, who's the head of the Coaching Academy here, that's going to run through part of the collaborative and the work we hope to do over the next few months, which is moving to an online approach. And then we've got Dr. Jenny Myers and Dr. Manu Vatish, who are national clinical champions for the Placental Growth Factor project. So they're joining us this afternoon and can answer questions. And we've also got Sue Wallace and Dawn Hannah from Roche and Quidel, who can also offer support. Obviously, they're moving with the times as well and changing some of their training to online and virtual settings, so they can help with that. And then just to kind of give a brief overview of who we are as the Academic Health Science Network for those that are not aware. So we make up part of a network of 15 of us across the country, and we're commissioned by NHS England, NHS Improvement and the Office for Life Sciences. Now we are the innovation arm of the NHS, so we basically help our NHS colleagues support them with the adoption of innovations, one of which is Placental Growth Factor, which has been established as a national programme. So just to give you a background to the Accelerated Access Collaborative, it brings together industry, government, regulators, patients and the NHS to remove the barriers and accelerate the introduction of proven innovations which can transform care. Now, last year, Placental Growth Factor was looked at one of the late stage products and it became known as what we call now a rapid uptake product. And it was selected because it has proven guidance behind it, being recommended by NICE, it delivers clinical benefits, cost effective, and the adoption was lower than expected. So the AAC, or the Accelerated Access Collaborative, decided that it should be put under the Rapid Uptake Product Programme, which meant that it has a wraparound support with us as the Academic Health Science Networks supporting that rollout across England. Placental Growth Factor is also what we call under what we call the Innovation and Technology Payment Programme, which basically removes the financial barriers. So this year and rolling up to March 2021, it's actually the assays are being funded under zero cost, which basically removes that barrier of getting that initial cost and roll it out across the system. So what we're looking to do as a collaborative is basically help our sites support with the rollout of Placental Growth Factor-based testing. Now, obviously, we'll work with each of the sites to kind of look at what their standard protocol might be, and we might obviously help them with any COVID-19 related pathways that they want to put in place. So I know Dr. Myers and Dr. Vatish are working on their own protocols. I'm hoping that they'll be able to share those either today or in the next few weeks and can help with questions. And part of the collaborative setup is to support sites working together, sharing ideas, sharing learnings and sharing the data. So we're hoping that by the time we've kind of gone through these workshops and webinars that we can support each other to kind of bring this forward and get women really the care they need. So we do have some enablers already in the system. So, you know, as teams working together on with the NICE guidance.
Sorry, Gemma, we've got Mandy that just wants to ask something. Hi, Mandy.
Hi, Mandy.
Hi, I'd just like to say that the Patient Safety Collaborative is part of this team as well, and we're willing to help support any COVID-related 19 things too. So that was all. Thank you.
Thanks, Mandy. Yeah, so Patient Safety Team are, of course, one of the enablers as well, and they have sort of a vast network and already very up with all the innovations that can help with that as well. So there are resources already in place. NICE having a great adoption toolkit if people want to go and have a look through that. They've got some great questions in there to support with looking at pathways. Obviously, we're collaborating across the Northwest Coast, across Lancashire and South Cumbria and Cheshire and Merseyside, as well as nationally. So we do have obviously our national clinical champions today from Manchester and Oxford, as well as other sites which we can signpost to and collaborate with. Obviously, you can engage with your local academic health science network, the Innovation Agency, and we can support with the measurement of that impactful change. Look at innovations that can help with any kind of related changes in protocol, especially with COVID-19. There's lots of home monitoring resources and innovations we can tap into. Sorry, I don't know if you can still see the slides. I've just knocked off.
Yep, but we're still on the enablers slide.
Okay, don't worry. Sorry, I just had a message with my network cutting out. So, okay, bear with. So, just to finish on that, obviously we've got Roche and Quidel online today as well. We've got who can support with the implementation and training and education, as well as our coaching academy, which Jen is kindly going to go through what their support can give us as well. I was also just going to touch on what we'd call the MedTech funding mandate, which was a new policy which was supposed to apply from the 1st of April this year. It's more just to say, so Placental Growth Factor will have funding now for centrally until 1st of April next year. However, once that kind of comes to an end, it's going to transition to what we call the MedTech funding mandate. Now, this was part of the long-term plan, meaning patients will get access to technologies faster, and it will mean that the funding will move from being centrally funded to being locally funded. Now, part of the reason I mentioned this is more around the data collection and capturing those improvements, because they will form part of what may be needed for business cases to support that locally funded case for Placental Growth Factor moving forward. And I know both our clinicians and the suppliers have some good data collection slides. So I'm just going to touch on what is required currently for the reporting. And this is for the innovation technology payment. So it's very minimum data set, which is submitted every quarter. The first one is due the 24th of April. We appreciate, obviously, in the current climate that this may be difficult, but we're here to support you wherever we can. Myself at the AHSN and the suppliers, as well as the clinicians, we can help you with identifying where you can get this data. And obviously there may be other data that we want to capture, and I know probably Jenny and Manu are going to touch on that. So, Jen, I don't know if you want to take over and say a little bit about the Coaching Academy.
Thank you. I would love to. So thanks, Gemma. Hi, everybody. My name is Jen Cohan, and I am the head of the Coaching Academy at the Innovation Agency. And what we do is we support all of our teams throughout the agency and really throughout the whole region who are doing implementation, education, innovation work in whatever discipline it might be. Whether it was this morning we were working on cardiology, and today we're obviously working on women's and children's maternity issues. So I just wanted to welcome you all, because even though we were going to spend the day together working on this project, we're going to, I think, begin the collaboration obviously here online. And before we hear from our two primary panelists, I wanted to invite those of you who are joining us and listening to take a moment now and just think about some of the questions that you might have about using the PLGF process, implementing it at your sites. And I'll just invite you to use the Q&A function again at the bottom of your screen. If you hover over the bottom of your screen with your mouse, the Q&A box will pop up and you can type in any questions that you have. So we just wanted to give you a second to think about what are your burning questions before we hear from our panelists, our clinical champions. And obviously you can write them down as they're speaking as well, but we just thought we would front load those folks with some questions. And then after that, after folks present their information, we're going to have some more time for Q&A. So if stuff comes up in the meantime that occurs to you, you can either write it in the chat box, or you can hold on to your question and raise your hand later, and we have some dedicated time for that. And then at the very end, we'll talk about what's next and what are we going to do here in this collaborative space remotely, and how can we support one another in making sure that this work moves forward in an efficient way and keeping women out of hospital. So let's see here. I think that's pretty much it for me. So Gemma, do you want to introduce Jenny? I think we've got Jenny's here now.
Yep, hi. I'm not sure if you still hear me. So we've got now Dr. Jenny Myers, who's from Manchester. And she's going to run through her protocol and hopefully give us some practical tips with implementation. Don't know if we've had any questions as yet. I know Jenny was hoping that we might get a bit of questions before she started. Got quite a few slides.
We haven't got anything just yet, Gemma, sorry.
Oh, it's all right.
Can you hear me? Can everyone?
Yes.
Yeah. So I guess, Gemma, before I start the presentation, it might be just because I came in a couple of minutes after you'd started, just to know who's on the call and just what, where people are up to in terms of, what sites we've got, what hospitals we've got represented and where people are up to, just to give me an idea of where to pitch things.
Yeah, so I can see we've got Ali Linton from Morecambe Bay. So they're using Quidel up in Morecambe Bay.
Right.
Jane Oakley from East Lancs, who are also using Quidel. Who else have we got? So all our sites, Jenny, are kind of relatively new. Apart from Lancs Teaching and Liverpool Women's, which we use in Roche for some time.
Yep.
So,
okay.
yeah, I guess a good, like, your overview of kind of the clinician's perspective, because I know they've had, obviously suppliers have supported them, and we've got Dawn at Quidel who supported those sites, as well as Roche, Sue at Roche. So I guess a bit more of kind of your insight.
Okay, cool. And have you got my slides there, or do you want me to put my slides from my screen? Can you put them from your screen?
Yeah, bear with me.
Or I suppose, yeah, I'll just say, are you okay to advance them, or yeah?
No, that's fine. If you just say next, I'll
fine.
I'll read it along. Just bear with me.
Manu was trying to dial in. I don't know if he if he's managed it yet. I think he got booted off, so he's going to try and reconnect.
He did. I think he's trying again. So. Right. Okay.
Hi Jenny, it's Carla from Vatish. I'm just helping with the facilitation of today. I just want to make sure that you can see that Q&A at the bottom there, just in case anyone types anything into you. It's just at the bottom of your screen. If you hover your mouse over there, hopefully you'll be able to see a function for Q&A.
Oh yeah.
That's where the questions will come into you if we do have any that are written.
So will it kind of just say 1, 2, 3 if there are questions in there?
That's right, yes.
Right, okay, cool. All right, that's fine. Great. So as Gemma's already said, I'm just going to talk a little bit about the background for this test, the clinical background, and touch on some of the biology, I guess, and some of our experience in some of the early studies. And Manu will share some experience with some of the other studies that he's been involved with as well. So next slide. Okay, so we know that a large number of women will present with symptoms or signs, most commonly hypertension, as being a trigger for a hospital episode. And it's the most common reason that women interact with day units and antenatal clinics, as we all know, is a suspicion of preeclampsia. We know that the burden of disease remains very high in terms of NICU admissions, preterm births, lots of morbidity for the women. And we also know that in some circumstances, not all, but in some circumstances, being confident about the diagnosis can be quite difficult. And also in some situations, it's been nice to have some reassurance that a woman who's had a couple of blood pressures of 140/90, for example, but no other features that you're worried about, it would be nice to know that she's not got preeclampsia, and be able to return her to a kind of lower level of surveillance than you might have otherwise been able to do. And although we know that there are high-risk populations amongst our antenatal populations, around 50% of cases of preeclampsia are actually develop in women who didn't have any prior risk factors. So women who don't have a history of previous preeclampsia, for example, or women who don't have any other obvious risk factors for developing the disease. Next slide. And so we've known now for about 10 or 15 years that in women who develop preeclampsia, if you look at the placentas after delivery, there's a lot of evidence of placental damage, oxidative stress, abnormal turnover within the placenta. Often we know these babies are growth restricted. And several studies now, lots and lots of studies have shown that in the setting of placental disease, these two biomarkers, soluble FLT and PlGF, which stands for placental growth factor, are abnormal, and you can measure those in the maternal circulation, and much of what we measure in the maternal circulation is derived from the placenta, and so they're a way of assessing the function of the placenta, and we know also that they're likely, particularly soluble FLT, is likely to contribute to some of the features of the maternal syndrome that we recognise as being preeclampsia, so high blood pressure, proteinuria, and other features of endothelial dysfunction. And so loads and loads of research now which shows quite definitely that these biomarkers are associated with the condition that we recognise clinically as being preeclampsia. Next slide, please. Placental growth factor people will also have heard about in the context of screening for preeclampsia, and just to make sure there is no confusion, it is the same biomarker, but what we're talking about this afternoon and in terms of the implementation of this test is very much for the diagnosis in the 3rd trimester of placental disease. We're not talking about using it as a screening test in the 1st trimester. Next slide, please. So one of the very first studies that demonstrated that these biomarkers were useful in detecting women who were going to go on to get preeclampsia was the Pelican study. And this was a study that was run across several sites in the UK. And we took women who came to day units and antenatal clinics with raised blood pressure or other symptoms that we might have considered to be attributable to preeclampsia. And we looked at the likelihood of this test, the placental growth factor test, identifying those women who were going to run into problems needing delivery within the next 2 weeks. And the important take-home messages from this slide are that the test was able to pick up the vast majority of women who were going to go on and develop problems requiring delivery within 2 weeks, but also very importantly able to rule out, so the negative predictive value was very, very high. So that means that if you had a negative test, your likelihood of needing delivery within the next 2 weeks with preeclampsia was extremely low. It's worth just saying that this study, like the prognosis study, which was pretty much the same study but with the Roche platform, this study was done with the clinicians had no knowledge of the blood test. So the blood sample was taken, the women were managed as normal, and then we looked at the blood results after the effect. So this study happened to be done on the Quidel platform, and using the PlGF only test. And if we move on to the next slide, the prognosis study was a very similar study across lots of centres across Europe, which used the Roche platform and worked out what the Roche, what the cutoffs needed to be to rule in disease, rule out disease. And like the Quidel platform, there was an intermediate group, and they showed almost exactly the same sensitivities and negative predictive values for signs and for delivery requiring or for predicting preeclampsia, and therefore the complications that arose. So studies done with a blinded test on both platforms showing very, very similar results, which made us all very interested to know how this would work in clinical practice. If we can move on. And so on the basis of those two big studies, the NICE Diagnostic Assessment Panel recommended that we should be using this test to rule out disease in women with preterm suspicion of preeclampsia. So in a group of women where the diagnosis of preeclampsia wasn't obvious when they first attended at the hospital, but where follow-up was going to be necessary, that the test was useful in terms of ruling out the disease for the next 7 to 14 days. If we move on. So in Manchester, while we were waiting to do the next sort of definitive implementation study, we did a study where we implemented it just within a sort of research context in our hospital in Manchester, and we really used it predominantly in high-risk women where the diagnosis of preeclampsia was not necessarily obvious. So a lot of the women that we included in this study were women who had pre-existing hypertension, pre-existing diabetes, pre-existing kidney disease, where making a diagnosis of preeclampsia is commonly quite challenging. If we move on. And what we showed in this study, if you just move it on, Gemma, that comes up with some stuff, thank you, is that women, 3 important messages really from this study, which was 260 women, that all of the women who had a low PLGF, so that would be the equivalent of a high FLIP PLGF ratio, in this case it was a low PLGF, all of those women had abnormal pregnancy outcomes. So universally those women delivered either preterm or had fetal growth restriction, demonstrating that this test really does line up very well with placental dysfunction. But what's really important is that lots of these women had very low levels of placental growth factor and would have had very high FLIP PLGF ratios, but their pregnancies continued for longer than 2 weeks. So the really important message for clinical practice there is that even if the test confirms placental disease and confirms a diagnosis of preeclampsia, it absolutely should not be used as an indication to deliver the baby, particularly where that's a very preterm situation. And that's really important for implementation, and perhaps we can come back to that later. Okay, if we move on. in terms of, and just move on, yeah, so in terms of the clinical management, we didn't have a huge impact in this study on admissions, mainly because lots of these women had other reasons to need to be in hospital because they had other medical complications. But we did reduce the number of scans that we did in this group of women, and we did reduce the number of outpatient attendances, and that's been echoed in all of the other studies that have been done. And the other thing that we made a big impact on is the number of babies that were born preterm. So a number of preterm births were avoided as a result of using and acting on the result, and there were a number of babies that we delivered earlier than perhaps we might have done because we had confirmation of that placental disease. So it allowed us to risk stratify quite carefully, and clearly there's an important trade-off to be had there about making sure that we're delivering the right babies preterm and not increasing the number of unnecessary preterm births, and that's something else that we need to think very hard about. If we move on. So the Parrot study, which I'm hoping most people will be aware of, was the next big study. Again, just happened to use the Quidel platform PLGF only test, but would have been generated the same findings if we'd used the flip PLGF ratio test. And what we did in this study is we rolled out the testing to a number of units across the country, 11 sites across the country, and then each unit was randomly switched over from doing a blood test but not reporting the results, and that's called concealed testing. And then each unit then changed over to doing revealed testing, where we then reported the result and the clinicians acted on that result. And what we wanted to see, if you move on to the next slide, is to see, and the next slide, sorry, to see whether there was a difference basically in the outcomes in people who were using the test and acting on the results, and the people who were taking the blood sample but not acting on the result because it was concealed to them. And by the end of the study, you can see all the units have moved over to managing with the test result. If you move on to the next slide. We used a modified version of the NICE guidelines, and again, for those units that are using the flip PLGF ratio, there are equivalent threshold levels to these, and to manage women as being low risk, which is the green group, very high risk, which is the red group, and then this kind of intermediate group in the middle. Next slide. And these are the two groups. So there were 577 women who had a PLGF result which was acted on clinically, and 446 women who didn't. And the features of the two groups were pretty much the same in terms of the number of women who presented with hypertension, the number of women who had proteinuria, and the gestation at which women presented. So the two groups were pretty equivalent. Next slide, please. And what we demonstrated was that there was a significant reduction in the time it was taken to arrive at a diagnosis of preeclampsia, which is not that surprising given that this is a diagnostic test for preeclampsia. But there was a reduction in the time it took to arrive at that diagnosis, on average 2 days earlier, to make sure that women were on the right pathway of care. So that kind of confirmed what we expected to show. Next slide, please. But the thing that, this slide shows that there was no significant change in the gestation at birth. So we weren't causing a lot of preterm births, which was reassuring. And also we didn't increase the cesarean section rate, which is also a good sort of safety barometer. Next slide, please. But the really interesting thing about this study is that although the very severe adverse outcomes were very rare, as you would expect, we actually reduced the number of adverse outcomes that were seen in the women where the test was revealed compared to the group where the test was concealed. And that was really one of the most important findings of the study. And what that shows us is that by getting the right women onto surveillance pathways and getting the right women into having regular outpatient attendances or even inpatient monitoring means that we're much more alert to the possibility of women developing complications, and therefore much more likely to act in a timely way. So that was that was very, very reassuring to see that we were actually making a difference in what we're all trying to prevent, which is severe maternal consequences of pre-eclampsia. Next slide, please. No significant difference in neonatal admission rates, which was reassuring, and no other significant differences in perinatal outcomes between the two groups. Next slide, please. So the Parrot study really confirmed what all of the other previous studies had shown, that using PlGF testing, be it the Quidel platform or the Roche platform, is likely to improve the accuracy of the diagnosis that we make as clinicians, and also, if used properly, has the potential to reduce the number of severe maternal adverse outcomes that we see associated with the disease. Okay, next slide. I suspect Manu will talk about this in more detail. A very similar kind of approach, and in terms of understanding how implementation will make a difference in clinical practice, was done in a study led by Manu in Oxford, and I'm sure he'll tell us more about that study, confirming the usefulness of the test. And that study was done using the ratio test. Next slide. And this is some money around, some calculations around the net savings, which is perhaps not super relevant just at the moment because the test is paid for, but ultimately the Parrot study showed that there was a cost saving associated with using the test, even though it's not a cheap test. Even when we have to pay for it, it's not a cheap test, but that there was a significant cost saving to be had across inpatient admissions, HDU admissions, and outpatient attendances. And that's really important in terms of preparing business cases moving forward. Next slide. I hope you've all seen the new NICE guidelines that have got management of hypertension pathways in, and placental growth factor testing sits within there. It's in that middle box in that sort of turquoisey green colour, and it's deliberately there as a very minor part of the whole algorithm for managing hypertensive disease in pregnancy. And I think that really highlights the fact that this is one test which is part of a holistic assessment of women with hypertensive disease in pregnancy, and that you know, it is part of an assessment, and it doesn't replace any of the other components of the assessment at all, but it does help to clarify some of the diagnostic uncertainties with diagnosing preeclampsia. Next slide, please. The new, we can move past this actually, it's just international guidelines, it's not really, so I think we see a lot of this. A lot of people tell me that they know how to diagnose preeclampsia. They've been diagnosing it for 30 years. Why do we need some expensive new test? And this is just to remind me to say that in lots of women, we don't need an expensive new test, because in lots of women, the diagnosis is straightforward. They present 29 weeks, new hypertension, new proteinuria, small baby. We don't need to do a test in that group of women to confirm they've got preeclampsia. They've got preeclampsia. But this test can be very useful in women with gestational hypertension, in women with gestational proteinuria, and in women who have got other medical disease which confuses the diagnosis, particularly chronic hypertension, diabetes and kidney disease as common examples. Next slide, please. And these are a few, I mean, these are old case examples now, and we've got lots of other case examples. I'm sure Manu and I have got lots and lots of cases now, having been using the test clinically for some years. But these are just a couple of cases where 2 women with diabetic nephropathy, one with a very low PLGF, almost certainly has placental disease that would have been difficult to determine otherwise. One with a reassuring level of placental growth factor, suggesting she almost certainly hasn't got placental disease, and that changed the management for those 2 women. And the lady in the middle there has got renal hypertension, and although she needed delivering early because of a deterioration in her renal function, but all of her other numbers suggested she'd got severe pre-eclampsia. But because she had a very reassuring level of placental growth factor, we were able to measure. We had to deliver a preterm, but we were able to hold off things like magnesium sulfate and high dependency care for her, because we were reasonably confident that she didn't have placental disease driving the change in her maternal parameters. Next slide, please. So this is the workflow that we currently use in Manchester. We do the flip PLGF ratio test in Manchester because that worked more easily for us from a laboratory perspective. And this is the kind of flowchart that we use, and there are various different versions of this around the country. The most important aspects of this are, if the diagnosis is obvious, you don't need to do a test. If the diagnosis is not obvious, then consider doing a test. Do all the other components of your assessment of the woman as you would normally. And if the test is abnormal, then she needs managing by a senior clinician with either inpatient or very close outpatient surveillance. If she's got a normal test, then we would usually discharge her for 7 or 14 days, depending on what the other parameters suggested and the other assessments that we've made. And if she's got an intermediate test, usually you're not much further forward than you were before you did the test, but you need to keep a close eye on that woman, because a significant proportion of those women will go on to develop preeclampsia, probably about 60%. So that's how we use the test at the moment in Manchester, and I'm obviously very happy to discuss that and how we manage women if people want to ask any questions. Next slide. I think that's probably me done, is it? Yeah, we don't need to, that's just how many tests. Yeah. And I think we perhaps can talk about this later in terms of the data collection and reporting. And I've got an example as well of the spreadsheet that we're using in Greater Manchester across the various different units to collect some additional information to help inform business cases for all the units, just looking at who they're doing the test in, what happened to those women, and what the final diagnosis and gestation delivery was. So pretty simple, but I can share that if anyone's interested. I've got it on my computer, so I can share my screen if anyone wants to see that. Okay, I'll stop talking.
Thanks, Jenny.
That's okay.
I don't know if you can still hear me. Yeah. Thank you for that. And I don't know if we've had any questions come through. Carla, I don't know if you can see that.
We haven't, no, nothing through the Q&A, and we've got no raised hands.
Jenny, I know I mentioned previously in the call just about, obviously you're working on your COVID-19 home monitoring protocol.
Yes.
Are you happy for us to share that with after this? Or?
Yeah, absolutely. Yeah, I mean, it's a little bit of a working draft, and it's kind of evolving. I might have changed it slightly since the version I sent you a couple of days ago, but Manu's got a very similar version of and there's actually going to be guidance on the college website, I think probably either today or Monday, also providing some information around using home blood pressure monitoring and thinking about using PLGF-based testing. So there's not, in the college guidance, there isn't going to be anything specific about using PLGF testing, but in terms of, you know, specific pathways or anything, but in terms of the recommendation that people should be trying to use PLGF testing to, particularly for its rule out, trying to keep women out of hospital and away from clinics as much as possible. And obviously outpatient blood pressure recording and monitoring can be part of that risk stratification potentially. So I think I'm very happy for you to share the pathways I've sent over, and there will be more pathways I think available, or there certainly is guidance going to be on the college website as well that people can potentially use and modify for their own purposes.
Yeah, no, that's great, because I know we might get questions asked about that, so I appreciate that. Thank you, and thank you for your time today. I know you've come from a busy clinic to join.
It's okay. It's okay.
Yeah, thank you. Appreciate that. So I'll hand over now to Dr. Manu Vatish, who is the Senior Clinical Fellow in Obstetrics and Consultant in Obstetrics down in Oxford. And he'll probably correct me now, so.
It's fine, I'll answer to most things. I'm going to try and share my screen if I can.
Yeah.
And then you'll end up with this weird thing where you're looking at yourself, I think. Can you see?
Yeah, we can see that. Yeah, thank you.
Let's see if I can make. No, okay. It's just not going to let me do what I want it to do. But anyway, no, it's not going to let me do that either. Okay, let's do it like this. Can everybody see those slides?
Yes, we can.
Yes.
Okay. So I feel as if I'm just going to be, without a pun intended, parroting what Jenny's just been saying. Let me just go through the way I try and make people or make myself understand about these biomarkers is I try and sort of work out, you know, how they change and how they evolved. And so if you look at the pathogenesis of pre-eclampsia, and you can see that you've got all these environmental factors here. And I think the big change came to the way that we manage the disease from a guy in Harvard called Anant Karamanchi, who in 2003 found that the placenta releases something called soluble FLT1. And so we know that the disease causes endothelial dysfunction, and the endothelial dysfunction causes problems with hypertension, the kidney, the brain, the liver, etc. And so what does this soluble FLT do? So what we have on the left here is a normal blood vessel, and the normal blood vessel sitting there with its receptors for PlGF and VEGF, and both PlGF and VEGF are growth factors that make blood vessels happy. So if the PlGF and the VEGF can hit these receptors, the endothelium's happy, it's relaxed, it's in a good place. The problem that occurs in pre-eclampsia is that you've got a lot more of this soluble FLT floating around. And what the soluble FLT does, it's a soluble version of this receptor that normally sits on the endothelium. And because it's floating around, it binds the VEGF and the PlGF, and it stops it from hitting the blood vessel walls. And so you end up with impaired relaxation on the unhappy endothelium. And so the way that he did this, and he's a nephrologist, so I find it, A, he's a nice man, and B, he's a nephrologist, so it's doubly painful that he did this work. But what he did was he looked at a large cohort of women, and he measured the soluble FLT throughout pregnancy. And you can see in the blue line, it says normal, healthy controls. As the pregnancy continues, you get this gradual rise in soluble FLT as you get towards the end of pregnancy. In the women who had pre-eclampsia, they had really high levels of soluble FLT. And in the women who got pre-eclampsia a bit later, the soluble FLT was higher than control, but not quite as high as the women with the established disease. If you look at the PlGF, and he measured the PlGF in exactly the same cohort of women, PlGF has a slightly different pattern of expression during pregnancy. So it goes up and then it starts to fall. And when you look at those exact same women who had pre-eclampsia, the PlGF was extremely low. And when you, as you would expect, because the soluble FLT is mopping it up. And then in the women who developed pre-eclampsia later, it was lower than the controls, but not quite as low as the women with the established disease. And so if you look at what the situation is in normality, you have lots of VEGF and PlGF and not much soluble FLT. And that's a very good pro-angiogenic state. And in pre-eclampsia, you have lots of soluble FLT and less free PlGF and VEGF, and you have an anti-angiogenic state. So what you can do is you can look at the imbalance that there is by either using the soluble FLT PlGF ratio or the PlGF, and they're both a readout of how much PlGF is being sequestered away. And so either one is perfectly appropriate and perfectly reasonable, but I'm going to mostly talk about soluble FLT ratio here. And so what do we know about it? So we know that if you look at women who've got the disease, and this is somebody called Roche Rana, who works in Chicago, but did this work in Boston. And when you get women, some of whom, 48 of whom have got preeclampsia, and 409 who haven't. If you look at the soluble FLT ratio, the soluble FLT ratio is elevated in the women who have preeclampsia compared to the women who don't. And importantly, she showed that if you wanted to use the ratio, you could use it to predict an adverse outcome, very similar to what Jenny said for the PLGF. It predicts an adverse outcome, particularly at less than 34 weeks. And so you can see this ROC curve. If you've got a line between this corner and this corner, this line here, it means it does nothing. And if you've got this line in the blue, which is the soluble FLT ratio, it's much better at predicting an adverse outcome than either the uric acid or the systolic blood pressure or the creatinine or the ALT. So very, exactly as Jenny said, a lot of clinicians said, well, I'm a very good clinician. I don't think I need a test to tell me he's got preeclampsia. I can do it myself. And so the idea of using those red lines where the value is altered but not quite as bad as the established disease was the idea came to see whether you could use it to predict who's going to get disease. And this was a prognosis study, and it's a prediction of short-term outcomes in pregnant women. It was a study that involved 32 study sites around the world, and 1,200 people enrolled into the study. And effectively, it was asking two questions. Is it possible to rule out the disease in the following 7 days in women between 24 and 37 weeks gestation? And is it possible to rule in preeclampsia in the women in the following 4 weeks between 24 and 37 weeks gestation? And exactly the same slide. It's very good at ruling out, extremely good at ruling out, exactly the same as the PLGF. Not quite as good at ruling in, but those of us clinical people in the audience will know that 36.7 is actually a lot better than what we currently do with other things that we do. What else can the ratio do? If you have a ratio, so the way this was done was that they used 500 patients to develop a cutoff. And so the development cohort developed a cutoff of 38. So then the 38 was tested in the validation cohort, and that's what gave the numbers. So what does this ratio of 38 do? It rules it out for 1 week, but actually it rules it out reasonably well for several weeks. And so if you look at the negative predictive value over 1 week, it's the same number, but over 2 weeks, it's also equivalently good. Starts to fall a bit at 3 weeks, and 4 weeks, it's about 94.3%. The other things that it can do are that a ratio above 38, exactly the same data, very similar data to Jenny, not exactly the same, of course, but very similar data to what Jenny presented, was that having an abnormal ratio or having a low PLGF predicts a shorter pregnancy and a higher risk of preterm delivery. And so you can see that the women who had an iatrogenic preterm delivery had on average a higher ratio than the women who had a spontaneous preterm delivery or a regular term delivery. All these studies had been done as retrospective sort of, collecting things. So we decided we did a prospective randomized study looking at the evaluating short-term prediction of preeclampsia and eclampsia in pregnant women with suspected preeclampsia. And the acronym was INSPIRE, and it took us almost as long to come up with that acronym as it did to do the study. And so the way that we did that study was we brought patients in with suspected preeclampsia, and they all had a soluble FLT PLGF test. And then the lab decided to either release the results to the clinical team, and this was the reveal group, or not release the result to the clinical team, and this was the non-reveal group. And there was an algorithm very similar to the traffic light and the NICE guidelines algorithm. And so these patients are managed with the benefit of the ratio and the algorithm. These patients are managed with the algorithm without the benefit of the ratio. And what it showed was that it was very good at identifying patients who are going to get preeclampsia. So this is the same clinical group of people. When we looked at the people who we used the test to diagnose preeclampsia, we admitted all the patients correctly. Same clinical team without the benefit of the ratio, sent 3 people home who developed preeclampsia within 7 days. Actually, all of them within 3 days. The use of the ratio permitted better segregation of at-risk patients. So it allowed us to admit more patients at worse risk than the patients that we sent home. And it was more effective at discriminating and directing admission of patients at risk of adverse outcomes. I think the important thing is that when we look at the test performance, of the 256 patients we had with a ratio of less than 38, only one developed preeclampsia as an inpatient. And what that's telling you is that its rule out is exceptional. And so this is why the rule out for PlGF and the rule out for the soluble fluid PlGF is exceptional. There are very few tests like it. And I'm reminded of a negative fibronectin as one of the other few ones that works as well. And when we look at combining the ratio, so if we look at the standard clinical management and we look at the ratio alone, if you combine the ratio with management, you get a sensitivity of 100% and a negative predictive value of 100%. So as Jenny said, that we published this results and then we used it. So the clinical team, so most of the people on this paper are actually jobbing obstetricians, and so we have one obstetric physician, lots of jobbing obstetricians, and actually they were all so pleased with the way that the test worked that they didn't want to let the test go. So having used it, and I'm sure Jenny has found this when she's done studies, it's the clinical team that drive the test. And so we drove a business case, and the problem with the business cases, and this is one thing that you all need to do before you start writing your business cases, is you need to have a chat with your finance department. And it turns out that in the NHS, there are two completely different cost models. So there's the non-recoverable cost model, and that means costs that aren't really tangible, but like I didn't admit this woman to the hospital bed. Hospital bed costs 500 quid a night. I saved 500 quid. And some hospitals will accept that as a business saving model. And those business cases are really easy because the test will prove a benefit in that role. In the John Radcliffe, this model was not accepted, and so we had to develop a recoverable cost model. And this is where we calculated the costs of all the blood tests, the follow-ups, the scans that we didn't do, the CT that we didn't do, the midwifery time. The recoverable model, it's cost neutral. When you do a non-recoverable cost model, it's cost saving. And when we pushed the recoverable cost model, the trust accepted it. The trust will not accept a model that costs money in this current climate. So we got the business case approved, and the key to getting, I can only stress this, the key to getting this approved is to be best mates with the clinical biochemistry department. The opportunity for both departments not to be singing the same song is exceptionally high, and the trust will pounce on that. And so it's really important that the biochemistry department and the obstetric department work very closely together. So we went live in Oxford in 2018, and we went live in the Thames Valley in 2019, and we did that entirely through the AHSN. So the Oxford AHSN were brilliant, really helped us to roll it out, and they did exactly what it says on the tin for the AHSN. They really helped us to roll it out, and then they disseminated to the national AHSN. We know that the test has gone wider, and these are a list of some of the hospitals that are using the ratio test. And I'm just going to show you the ratio test, the algorithm that we generated originally, and I'm then going to show you the algorithm that we've now got in the current COVID crisis. So you can see that this was symptoms compatible with preeclampsia. That was any kind of hypertension, proteinuria, headache, small baby, abnormal Dopplers. And you can see here there's a zone here about the blood pressure, which these numbers have now changed, of course, with the new NICE guidance. But it was, if you had an abnormal blood pressure, don't look at the test, admit the patient and look after the patient. And you did the ratio, and we had the numbers from the trial put in here. So you can see that if you have a ratio less than 38, you've got a 0.4% risk of preeclampsia in 7 days, and less than a 3% risk of preeclampsia in 28 days, which meant don't admit them. And if you had a ratio above 85, in our hands, that was a 56% risk of getting preeclampsia in the next 7 days. And the key thing here was to get senior clinical review. And if it was at 6 o'clock in the evening or 8 o'clock in the evening, or you couldn't get senior review, then the advice to the juniors was strongly consider admission of this patient. If you get senior review, then they could manage that as they saw fit and monitor as if they're preeclampsia. And if you have this intermediate ratio, there's a 20% risk of preeclampsia in 7 days. And so we divided that out, that if you had no signs of end organ damage or proteinuria or other end organ damage, that could be ultrasound or anything else, then you can manage them as an outpatient. And if they had any signs of end organ damage, then monitor if they've got PET and consider admitting them. So with the current COVID crisis, we've done an update. So we've opened out the gestation to 37 weeks now, and you can see that again the blood pressure has changed here, but the criteria to admit, and of course the numbers change a little bit because we've opened out the gestational age, but actually remarkably similar for the negative predictive value. So 0.4% risk of in 7 days, 1.2% in 14 days. 54.7% risk of preeclampsia in 7 days, 67.9% in 14 days. So these need senior review and monitor for preeclampsia, either as an inpatient or as an outpatient. These don't need very much follow-up, and these patients need follow-up, no admission, and monitor as an outpatient. And what we're doing in Oxford is we're using home monitoring, and that's not, so we've designed this part of the guideline, and there's another team, Richard McManus, Lucy McKillop, and Alex Cairns, who are using these home blood pressure monitors and an app called BPM Health. And the way that they're doing this is that we use the ratio to decide whether to admit them or not admit them, or to identify if they're at risk. And then we use the blood pressure monitor in the app, and the app tells them to do the blood pressure. They can input the numbers into the app. The app sends the data to the hospital. It can be monitored. And if they don't send results, then the app texts them and says, you haven't put on a blood pressure today. You need to do a blood pressure. I think that the key thing here, I would say, is that these are still relatively low risk women, and it's higher than this. So these women are really not at risk. And so I think it's really good, it'd be very good practice not to be bringing these women into hospital for no reason at all, really, unless there's something blindingly obvious staring in the face. So I think the preeclampsia is a placental disease, and I think they're both disease, soluble FLT and PLGF are both disease-related markers. The ratio can rule out disease with a negative predictive value between 99.3% to 100% for the following 7 days, and it can rule in disease with a 38.6% PPV. You can see that if you use the ratio cutoffs that we've done, that increases. So that number is for 38 as a cutoff, but you can see that if you use 85 as a cutoff, you can get it up to as high as 55 to 60% over 2 weeks. Both soluble FLT and PLGF as a ratio and PLGF alone perform well. And I think the bottom line that I want to say is, but both these tests are better than standard practice. There is absolutely no evidence that they're effective above 37 weeks gestation, almost none at all. And we hear reports of people using them at 39 weeks and 40 weeks, and there isn't any evidence to support that. And I think when you're generating your guideline or your business case, use within the NICE guideline will yield the best results. But the current COVID crisis means that opening out these tests to later gestations means that you can keep expectant mothers home. And if you've got questions about this, I'm very happy to share the guidelines. If you've got any questions, you can just email us. Sophia is a clinical lecturer, very able clinical lecturer who I work with. And if you email me, I'm almost certainly going to palm those emails off onto Sophia because she knows much more about this than I do. Okay, that's all I got.
Thanks, Manu. That was brilliant. Thank you. Appreciate that. I will just open it out now to see if there's any questions from anyone whilst we've still got you both on the line. I don't think there's any that have come in, but no, thank you for that. Really appreciate seeing your protocol as well. I know you were kind of drafting it this week for the COVID-19 update, so appreciate that.
Yeah, we just got it approved, and the BPM Health app is not CE marked, but the trust just approved it. So it's actually the best app out there because it's been field tested by Richard McManus in his bump study. So it's the same app. So I would encourage you to email Alex Cairns, which that email address is alexandra.cairns@gmail.com. I would definitely encourage you to, if you're interested. I think the key here is that getting hold of those monitors, getting hold of those apps and things, I think it's just going to be difficult in the current climate. I think there's going to be enough calls on trying to get stuff to hospitals that would be mask and visors and PPE. So I think the way to do this is to use these tests to get that 70% of the patients who you'll see will have a low PLGF, soluble flip PLGF ratio, or a normal PLGF. Send them home.
Yeah, of course.
Hi, we have got a question. It's from Mandy Townsend, and it's to I think it's to yourself, Manu. It's have you looked at remote urinalysis too?
Yeah, they're all going home with a little pot of sticks.
Have you looked at the Hampton app as well, Manu? You know that's
No.
Is Jenny here? There are various, again, like the blood pressure monitoring thing, there are various apps, again, to take pictures of urinalysis sticks, the DIP.io app, and there are various other methods. But in the current climate, again, it's just about most women can understand how to read a dipstick. So if there are pots to give them, and finding a way to be able to communicate with them, I think in the current climate, you know, it'd be nice to be able to roll out lots of complicated apps with algorithms and stuff, but I think at the moment we don't need it. But I think if you're sending women home and you genuinely think that proteinuria testing will help, then I think giving women sticks, I think, is perfectly reasonable.
Exactly right, Jenny. It's just the low tech, in the current climate, low tech works.
Yeah, I think so.
Yep, great. Thank you both. I don't think we've got any other questions. Mandy says thank you.
Are there any comments from any of the sites that have already started using the test? Have they come across any issues that they wanted to discuss?
I think the main issues some of them were having were with the data collection, Jenny.
Okay.
Just, you know, identifying who's actually had the test.
Okay, well, Manu and I can probably talk to that a bit. So start my video. So on the ITP pathway, we have to collect these metrics, which are about how many women were eligible for the test in your hospital, how many women have had the test, and then what's happened to those women in terms of whether they got admitted or discharged. And there's been a lot of discussion about whether the first number, the number of women who would be eligible for the test in your hospital, whether that's a number that anyone can actually count effectively. And there are various ways of doing that, but I think I'm right in saying, Manu, that the guidance is going to come out quite soon, that is an aspirational number as opposed to an essential number. And so, especially in the current climate, it's just not appropriate to have midwives or clinicians trailing round, counting up how many people have come through the hospital with a suspicion of pre-eclampsia. So I think that number is at the moment less of a priority, and not going to be mandatory in the reporting. The second number, which is how many tests have you done, should be very straightforward, as long as there's a good relationship with the biochemistry department. That should be straightforward. I guess if people are using Quidel and they're doing it as a point of care test in a clinical area, then there needs to be some careful logging of the test being done. I don't know if the Quidel sites are doing it in a clinical area or if it's being done in a main laboratory. Does anyone know?
I think East Lancs are on. I think they're doing in the main laboratory.
I think the stipulation was to do them in the labs, I think.
Yeah.
So as long as so if they're being done in the labs, then and they're being reported on a clinical on a blood test result reporting system, then it should be very straightforward for the biochemistry department to just download how many tests have been done. And then it's not a difficult job usually to, can you still hear me? I'm having, yeah. So it's not usually a difficult job to then just work out which of those women ended up in hospital and which women were discharged. Generally speaking, that's not too difficult to do. I don't know if people have been having problems with that.
Apparently there's a message here, Jenny, that several trusts are delivering as point of care. So I think it would be important for them to generate a log, as you said.
Yeah, but I mean, presumably that you would hope that if Quidel's been used as point of care, that there is some kind of, because you have to record the QC process and the what cartridges have been used. It should be straightforward to people to write down the test when they've done the test. Someone should have, you know, oversight of the analyzer.
Yeah, I think they'll need some system, won't they? They'll need a clear system, otherwise it'll just get jotted down on little scraps of paper, and the little scraps of paper will just end up in a pile somewhere.
Yeah, there needs to be a definite log. Yeah.
This is Jen from the Coaching Academy. I was just going to say that's exactly the kind of thing that we can really work on together as folks are moving forward, is what are the best means of collecting that data and tracking it. So hopefully we'll be able to share some successes across sites.
Yes, I mean, if as I say, the two methods really available are either a download from the laboratory if it's being done in a central lab. If it's not being done in a central lab, then a very careful log system next to the analyzer, which is, you know, the people that are trained to use the machine should be absolutely logging the test and logging when QCs have been run and logging clinical samples, and then it should be straightforward for then someone to just find out what happened to that woman. I mean, it does take a bit of effort to find out what happened to the woman, but that should be doable.
Hi Jenny, just to read a couple of the messages, it's Carla again. So Dawn, who originally put that there were several trusts delivering as point of care, she said that trusts have developed logs for both the QC and numbers of tests performed.
Cool.
And Jane Oakley said at East Lancashire we're doing as POCT, and they are using logs to record all PlGF results.
Cool.
And Mandy has written that labs will have all forms logs that they use for POC glucose readings. Ask them.
That's useful.
Cool. So that sounds like that's reasonably straightforward then. And then I guess it's just the other bit then is working out whether the woman got admitted or not. And that just means having somebody usually that understands the hospital system and can either get the appropriate electronic patient record or electronic logging system or whatever to find out whether the woman got admitted, or otherwise the patient notes, I guess, if needs be. I don't know.
So we get a readout from the labs, and it has all the numbers. Some of the peripheral hospitals send. We have a satellite hospital, and that the labs can segregate those, and then we just interrogate our EPR, and it tells us whether we're admitted or not. So we just go date plus 1 day. Date of test plus 1 day.
Yeah. Yeah, with similarly here, not quite as straightforward as that here, but similar. Yeah. Any other implementation problems that people have come across?
We've got a Q&A. So this is Annie Linton. She's written, at UHMB, we are building a digital dashboard to capture this data electronically. No problem with the required data quarterly, but would be useful to see what other data other units are collecting regarding business cases, etc.
So if someone just talk me through how I share my screen, and I'll show you our very straightforward spreadsheet.
Yeah, lovely. So just at the bottom, the grey bar, if you hover your mouse further down, you should get an option to share.
Oh yeah, there you go. Look, that very obvious button. Right. Okay.
And also, just before, Dawn has actually said the Quidel Meter Pro records patient ID number, which can be used to cross-reference outcome.
Okay, so oh no, gosh! So now you can all see what rubbish I've got open on my computer. So can you see? Oh my word! No, you can't see anything except a load of rubbish.
If you click on share, it might give you a few options of which screen to actually choose to share.
Can you see this or not now? No.
You can just see a blue screen.
Blue, yeah.
Sorry.
So Jenny, at the top of your screen, it'll probably say stop share. And then and then if you try again at the bottom of your screen, it'll give you some options of which screen you want to share.
Oh, I see. Gosh. Okay, this one I think. What can you see now?
We're waiting. I think it's loading up. Maybe.
If not, Jenny, I've got your Excel spreadsheet open if you want me to share it.
Oh, there you go. Yeah, brilliant.
So
I failed the IQ test.
No.
No, don't.
Yay, there you go. That's what I had open before.
Yeah.
So, and this, if you hover over the various different columns, you can, there should be a little drop down for each box to just try and make the data entry consistent. And it's just a very low tech solution that we're running across Greater Manchester to just try and capture the journey for the women, when they were admitted, what was the reason for admission, very broadly speaking. And then if you just go over to why delivered in column L and click on that drop down, there's just some very broad groups there to just kind of give an idea of what the context of the delivery was. So those kind of bits are not necessarily essential for a business case, but they just give you a feel in your hospital for what's happening for the women and whether they were admitted or discharged, and what the reasons for those admissions and discharges were. So and that will just helps units to track kind of what's happening to their patients and to be able to monitor to a degree whether they're using the test reasonably successfully. Obviously, if you've got lots of women who are with green test results that have been admitted into hospital for monitoring for pre-eclampsia, then that's not, the test isn't working very well as one example. And if you've got lots of women with red test results who are being discharged home and not seen back for 2 weeks, then also that's not working very well. So so it's just a way of triaging and tracking what each hospital is doing. And because preterm pre-eclampsia is clearly a very important disease, but is still a reasonably uncommon disease, in lots of units, actually, even over a 6-month or 12-month period, actually the number of women with positive and negative tests will actually still be reasonably small. And so the idea certainly across Greater Manchester, and I'm sure across lots of other regions, is that we pool some of this data so that the business cases can reflect a bigger number of women and iron out some of the inevitable glitches that you see with exceptional cases in smaller units. So that's the idea, and what we're trying to achieve in Greater Manchester. So far it's going okay, but we'll see how it goes as we move forward.
Manu, you've raised your hand.
Yeah, it was just so we did so there will be a learning curve. I mean, so the units that have had the test for a bit longer will be better at this, but actually those units that have started using the test, its penetration of the test will not be 100% from first go. And so you sort of sit there and you'll see this patient, you'll go, of all the patients on the ward, this person should have had a ratio or should have had a PLGF test, and they're the only one who didn't have one. And so it's important that when you're doing this type of analysis, we'll have a similar sort of sheet. It's married by electronically, but it's very similar. But when you're doing it, you need to bear in mind that some of your patients, you know, for your own business case, when you're calculating the number of tests that you're anticipating using, if you only look at the tests that you did, you might be missing the tests that you should have done, as it were.
Yeah, that's a really good point. And I think we can, the audit numbers are quite useful for that, because you can see how many tests you're doing as well. And although that doesn't necessarily capture the appropriateness of the test, at least that each unit should kind of arrive at a sort of steady state, shouldn't they? You know, when they've built up some experience, so you can kind of see how that's tracking. I think that's useful for just being able to benchmark. The proportion of tests you're doing should be reasonably, you know, should be similar to other units, i.e. we should all be testing a similar percentage of people, and if you're testing 5 times more than another unit, you're probably doing too many, and if you're not, you know, if you're doing half as many as the next door unit, you're probably not doing quite enough. So within a margin of error, there probably is a way of benchmarking to see we should all be testing roughly a similar proportion of our antenatal community, and you can just work that out very straightforwardly by the number of births you have in your setting. There will be variation, but not that much.
I agree. I agree. The other question is about this, about business cases, is it's really worth having a chat with your finance department right now. And so to see whether they follow the recoverable or non-recoverable cost model, because you'll need to collect a different, the data you'll collect and the argument you'll make will be very different.
And just a last comment from Dawn. She said that the Quidel Meter Pro records patient ID numbers, which can be used to cross-reference outcome.
Yeah, that's really useful as well, isn't it? I mean, the more ways there are to cross-check and make the data collection process as easy as possible, the better. And it, you know, it's one of those things that each unit will find a way of doing it dependent on their, you know, their own circumstances. So it's always best, I think, developed by someone who understands how each unit works. But I'm happy for that spreadsheet or any similar version, you know, to be used, obviously to be shared and adapted as people see fit.
Yeah, thanks Jenny, and thanks Manu. I think that was really helpful, and I will share that spreadsheet like you've suggested and other protocols, etc. So yeah, really appreciate that. We're going to have like a shared collaborative site where we can put those resources on. So thank you, and I don't think we've got any other questions, but if we have any more, I'm sure we can follow up with them. So thank you both for your time today. I know it's you've had a busy day, both of you, so if you want to shoot off, feel free, but yeah, really appreciate your help today and your support.
Fine. Yeah, well, if you don't need us, we'll scoot, but just worth saying one more time that Manu and I were both delighted to answer emails or queries, or to chat with people on the phone if there are any other units that are near to implementing that we can try and help to get kind of get over the line, or if there are problems, clinical problems that we can help to just try and iron out. So please, do feel free to use both of us to help with that.
Yeah, thank you.
And the last thing is, I'm just going to reiterate something that Jenny said, which is, if the ratio is elevated, it's not an indication to deliver someone. It's an indication to watch that person and make an assessment. So and you'll all have this, when we had one patient who was 24 weeks with a ratio of 683, and everybody went, "What do we do with that?" And we said, I don't know. I've never seen a ratio that high. And so we just sat there and we watched the patient. We delivered the patient based on clinical grounds 2 weeks later. So it's not worth diving in. It's still only, so it's just important that its rule out is much stronger than its rule in.
Yeah, absolutely. That's really important.
Okay, I'm going to disappear.
Great. Thank you both.
Yeah.
Much appreciated. Yeah. Thank you.
Okay, thanks. Bye.
Thank you. Bye. Right, so I'm going to hand over now to Sue Wallace, who's from Roche, and she's our local contact there at Roche who can support sites. So she's just going to take you through a few key things that she can support our sites with. I think, Carla, you're going to manage the slides, aren't you, Sue?
Yeah.
Thank you.
Thank you. Sue, you should be able to share your video and to chat now.
Can you hear me?
Yeah.
Yeah, I can't get the video to, it says it's locked by you, but it doesn't matter. My name is Sue Wallace. I'm the outcome specialist for the North. Do you want to move to the next slide for me, please, Carla?
Yeah.
So I lead on supporting sites locally in the North for the implementation of the S-split1 PLGF ratio test. And I work really closely with Julia Eads, who's on this call as well. She's our market access manager at Roche. Just to point out at this point, before we move on to the next slide, in addition to the S-split1 PLGF ratio test, we also have the high sensitive troponin when used with a rapid rule-out pathway for the diagnosis of acute myocardial infarction, and that's also supported through the AAC and ITP. So this is the support that we offer sites working with Roche. So we offer healthcare professional education sessions, and absolutely I can revisit these to support with any staff changes in any sites. So far we have delivered 78 sessions in the North and educated 1,587 healthcare professionals in the North Territory only, which is amazing. We also have done that mostly through hangouts, one-to-ones, group sessions. Been doing quite a lot of mobile education sessions, going around wards and departments working with the midwifery teams. I've also recorded my education slides, and Gemma has a copy of them and she's going to upload them onto your resource centre. So you can access them there at any time that is suitable for you. I've got a team of around 20 within Roche that support us with individual trust needs. So we're absolutely flexible and able to offer what you need to support your teams. With the education, we also have certificates that we give out for education evidence, which is great for revalidation and CPD. And we have patient leaflets as well that can be modified with trust logos to be able to educate your patients on the test. Around the data collection review support, I facilitate project review meetings. So, for example, with Jenny Myers in Manchester, we have project review meetings there where we all sit down around the table and we review each site and individual data and work with both the lab and clinical teams to review what's gone well, what's not gone well, and what do we need to do differently. I definitely offer data collection guidance for submission to NHSA, and we will also are working with our sites around business case support moving forward, so that you're in the best place at the end of the project if you want to implement this service permanently. Overall, I think for me, we have 23 sites, 23 trusts in the North that are live using the S-split1 PLGF ratio test, just in the North area, and I lead in all those sites. So definitely there's a lot of continuity in communication, and like of Jenny's spreadsheet, I've shared that across all the sites in the North and sharing experience and best practice from the meetings that we're having across the North. Could you go to the next slide, please, Carla? In addition, these are additional resources available, and Gemma will put this up on your resource site as well. We have a module through the Healthcare Professional Academy. It's all around the advances in the diagnosis of pre-eclampsia. It takes around 40 minutes to complete, but you can download a CPD or certificate for revalidation again, or CPD, after you've completed the module. We also have YouTube videos where Manu and his team at Oxford have shared experience around their implementation. And we also have a video from a patient video where they share experience as well around their experience of the ratio test. So next slide, please, Carla. So Jenny's touched on this already, but Gemma mentioned to me there was quite a lot of questions around the data collection. This is a table that I send out to all of my sites, and it just gives a little bit more detail around the 4 key points that you're reporting back to NHS England. So yeah, as she mentioned, quite a few of the sites are using PCR tests as a guide to the number of women that might be clinically assessed as pre-eclampsia. And then, as Jenny's mentioned, it's number of patients who've received the test, number of women admitted, and then it's just a simple mathematical sum around the number of women discharged. So generally, we've sent this out to all our sites that we're working with. Next slide, please, Carla. And then I also thought it might be useful for you to see the formal Arden template structure. So that's on there as well. The next due date for the Q1 data is the 24th of April. I've got project review meetings booked with all my sites, and at this difficult time where I absolutely appreciate your resources are difficult, I'm actually going to be offering to support with submissions to AGIM for them, and where we will agree your numbers, and then I'm happy to submit the data and save you a job to do, just to try and support as much as we possibly can, and everybody support one another at this time.
Thanks, Sue.
And I think that's it. Thank you.
Thank you. Just conscious of time, but thank you for that. Appreciate it. And obviously we'll share these slides on our resource site, as you say. I'm just going to switch over to Dawn now, if that's all right, from Quidel. She's done a couple of slides for us as well to just show what support Quidel can give from their sites.
Hello.
Hi, Dawn.
Hi.
I'll just change your slides.
Slides for you now.
Hi. I just wanted to. Oops, hang on. Sorry, I've lost you.
That's great. We can see you, Dawn. We've got your slides. Can you see your slides?
No.
Can anybody else see them?
Yeah, I can see both sides. Yeah. John, if you there you go. Okay.
Yeah, got you.
Yeah,
okay.
lovely. Thank you.
My name's Dawn Hannah. I'm the clinical educator for PLGF at Quidel. And my background, I should say, is as a nurse and a midwife. I'm responsible for the education of all the Quidel sites across the country. So how can we help you? Well, we've got education for clinicians and practitioners, led primarily by myself, with experience of not only pre-eclampsia, but of caring for high-risk women and high dependency care, and education for midwives around pre-eclampsia. We've been providing support for trusts with financial modelling, support for developing the clinical pathways, and at the moment we are actually looking at implementing a home monitoring app as well, so that will be available to trusts. That app actually allows you not only to measure the blood pressure, but also to input urinalysis readings as well. As a company, we've actually developed a toolkit to support the implementation and preparation for the post-ITP period. And that toolkit is made up of several documents. So there's a business justification document that trusts can actually personalise, adding in their logos, their own information, depending on what model they're using for financial purposes. There is patient information leaflets, recorded educational sessions, the protocols and SOPs, various pathways that they can opt to use, as well as some of the research evidence as well. So we put on it anything that we think would be of value to trusts to really take some of the legwork out of having to spend time away from the clinical area. I think my top tips for implementation and things that we've found as we've gone along is about getting the right people around the table within the trusts, be they laboratory staff, point of care staff, finance staff, heads of midwifery, clinicians and practitioners. I think the other thing to say is it's important at the start to set a go live date so you've got something to work towards rather than procrastinating. But it's also important, we found, that if you work as a team and keep the end goal in sight is really key. I am contactable on my email, which Gemma can share, I'm sure. And obviously any help, any support we can give you at any point, you know, feel free to shout out. Okay.
Lovely. Thanks very much for that, Dawn. Fantastic.
Yeah. Great. Then thank you. And so, hi, I'm just gonna, I know we're at time, so just really briefly. So I'm Jen again, if you were here with us at the beginning from the Coaching Academy. And I'm just gonna share, here we go. A couple of very, very quickly, just to let you know sort of where we're going from here. Carly, can you just let me know, can you see the Z model there?
You can, yeah.
Okay, great. Thanks. I've just got some stuff covering it up on my screen. So our plan, we were going to spend the day together today, but we're spending some time remotely online together, which I think will quickly become comfortable for a lot of us. We're, you know, hoping over time now in these coming months to really harness the existing expertise that you are all bringing to this collaborative, all your experience that you've had. Some of you have been doing this longer. You've already started with the testing. Some of you are just starting. So we're here to sort of support that process and learn from each other. And then the offer here from the Innovation Agency and the Coaching Academy is to really help support you through coaching. So what that just means really briefly, let's see here, is, here we go. Is that by coaching, we're talking about just increasing your capacity. So for example, my background is not clinical, but as a coach, my job is to help you move from one place to another, whether that's looking at how do you build relationships with your clinical biochemistry colleagues, doing some stakeholder mapping, what conversations do need to happen with finance, how do we help you build your business case, and how do we help you collect data, make that more seamless, and also just navigate the human factor of decision making, and understanding your current process and how it differs from sort of where you want to be. So that's really our job. As just a review of sort of what we had planned versus what we're doing. Again, this is almost just a big PDSA cycle with a couple of different iterations. So instead of meeting face-to-face for our full workshops, we're going to transition over to some monthly webinars. In the next week, you're going to hear from us with an invitation to join a collaborative site, and then we'll start talking about when's best to schedule those follow-up chats with you and your team members and your colleagues and folks who are, those of you who are watching and listening to this webinar post our live broadcast here. So we'll come back together and we'll discuss where we've been and where we're going. So just again, in the next week, you're going to get an invitation from us to join the NHS Futures site. If you're not already on it, it's really slick. It's a single sign-on, and you can access a lot of different collaborations. That's where we'll house all of our resources. We'll have a discussion board specifically for you. We'll have a calendar with all the dates of any coaching that you might want, or webinars, or perhaps if our clinical champions are available for some questions, that kind of thing. We'll also have an ability for you to ask for more support. So perhaps there are some of you who are close in region and you'd like to do some of this exploration together, or maybe you've got a team and you want to pull together, you know, somebody from your biochem and finance and your other clinical teams together and have a chat together. We're happy to coach you through some of those discussions. And then we're also going to post what we're going to recommend for you in the interim between when we're on these webinars together, which will be, for example, I'm going to share with you more about encouraging you to do some stakeholder mapping, and just for the sake of time, I'm going to go through this quickly, and some process mapping. So those are sort of the two areas that we're going to encourage you to look at in the next month or so, and that's sort of it for me. So you can just know that you're gonna hear from us, and we're here to help you. This is just the beginning, and we're really looking forward to implementing this work so that we can keep women out of hospital and babies in bellies as long as they can be. So that's it for me, Gemma.
Thanks, Jen, and thank you everyone for joining us today. I appreciate you all giving us your time today. As I say, the recording will be sent out and online, and we'll get that round to you as soon as possible. So thank you all.
Yeah, thanks very much. So I'm going to stop recording now. There are no further questions. Yeah, lovely. Okay, thanks everyone.
Thanks all.